diabetes, but if your mom has gestational diabetes, are you more likely to develop PCOS?
Yes, so it seems they are able to see this clearly in animal studies that if the mother has insulin resistance during pregnancy, it will turn on the genes for insulin resistance generally, and that is related to certain types of PCOS. So
welcome back to the PCOS Holistic Coach podcast with me, Dr. Ami Patel, pharmacist, fellow sister, and coach. This podcast is an easy-to-listen-to resource for your busy, on-the-go life. You will learn how you can live a healthier and happier life with PCOS from real conversations about managing PCOS and the symptoms with amazing guest speakers.
Okay, welcome back everyone to another conversation within the PCOS Holistic Healing community. Really excited to have an amazing guest speaker today. I feel like I say that before every episode, but all my guests are amazing. But this one is extra amazing. Okay, Dr. Fiona McCulloch is here with us. For those of you that have possibly had PCOS for a while and have been trying to learn more about it, you may have come across of her book and a lot of her resources that she has. But to go more into detail, so Dr. Fiona McCulloch is a naturopathic doctor and founder of White Lotus Integrative Medicine in Toronto, Canada, an urban wellness clinic serving thousands of women with hormonal conditions since 2001. Dr. Fiona's book, right here, 8 Steps to Reverse Your PCOS, offers well-researched methods for the natural treatment of Polycystic Ovary Syndrome. Dr. McCulloch is also a medical advisor to and developed the nutrition methodology for the OpenSourceHealth PCOS project which analyzes molecular, genetic, metabolic, and hormonal markers in women with PCOS. And as a woman with PCOS herself, Dr. Fiona feels fortunate to serve as a guide, providing trusted information that empowers women to manage their own health. So she is an expert and she has her own personal experience with PCOS. So I'm really happy to have her here today. So thank you for being here.
Thank you, Dr. Patel. It's so nice to be here. We met at the PCOS Challenge symposium. So it's been great to get to know you and see all the work you're doing.
Yeah, we have so much similarities with our own personal struggles with PCOS, which have led us to do something about it and be advocates in the field, which is how we met through PCOS Challenge and how we're having this conversation here today.
Yes, it's so important, the advocacy element. It's made so much of a difference over the past, decade. It's amazing.
Yes, definitely. And I love your book and how you manage and treat PCOS, which we are going to talk about today. And today's general topic is gestational diabetes, but we will discuss a little bit about other things as well. But to get started, based on your research and knowledge, what are some causes of PCOS?
Yeah, so for a long time, we actually had no idea what caused PCOS, even though it's very common. But in the recent years, it really looks like it's caused by a combination of genetics. So there are certain genes that make you more likely to have PCOS, or they're actually identifying what those genes are. And then something called epigenetics, which means basically how the environment turns off and on genes. And a lot of this actually can happen developmentally while we're developing as a fetus. We have certain kind of predispositions in our genes, and then environmental influences, that might be something in our mom might have some insulin resistance, or it might be an environmental endocrine disruptor like a plastic exposure. Many things in our environment can turn these genes on. So it's really considered to be a combination of those two things that causes PCOS.
And going off of what you were talking about, so does that mean that we are going to talk a little bit more about gestational diabetes, but if your mom has gestational diabetes, are you more likely to develop PCOS?
Yes, so it seems they are able to see this clearly in animal studies that if the mother
Mm,
has insulin resistance during pregnancy, it will turn on the genes for insulin resistance generally, and that like is related to certain types of PCOS. So absolutely,
oh,
and then the androgens too in pregnancy can also be part of that. So yeah, it does seem to be correlated. Now they cannot obviously do these studies ethically in humans, but they can
right.
look and see, animals and then also look at humans that had those and what was the outcome later. So yeah, so it's really interesting, and that's a lot of why I find it so important to really understand gestational diabetes because it can be missed very easily.
Yeah, and like that just makes me think like, it's kind of like a unfortunate like bad cycle, right? That we have to kind of learn how to manage so that we can break it so that we aren't like we reduce as much as we can that's in our control of passing it on, and not only that, but also helping ourselves.
Yeah. It's true. And the genes for diabetes are strong genes. So, pregnancy, we shouldn't blame ourselves because pregnancy just turns those genes on. And sometimes we
Mm,
cannot do anything about it. It gets, but like there's a lot of the time where if you can identify it happening, you can really make it so much better. And
right.
especially if you can identify it early, you can make a huge difference. So if you kind of have those genes and they're that strong that they turn on, those are genes you're probably passing
Right.
on rather than causing by, so we shouldn't really blame
Right.
ourselves. But, just knowledge is really important and understanding it.
Yeah, that makes sense. Like, they're your genes, it's how you're made. You can't help it, right? I guess
Exactly.
just as much as you can't help like the color of your eyes or like the color of your hair, right?
100%. Yeah, it's there. We know it's there. And then, we do whatever we can. But the most important thing is just to know about it. So you can
Mhm.
advocate for yourself if you feel like something's going on.
Yes, which we will talk about. But what is your personal connection to PCOS and gestational diabetes? If you could share that.
Yeah. So I had, it's Sandro. Hi, Sandro. One of our amazing
Yeah.
PCOS researchers here. So basically, my screen has frozen. I don't
Oh,
know.
it's not frozen for me.
It's not, eh? Okay. So I'll keep
Mhm.
chatting. So yeah, so basically my personal experience is that I had a lot of, hormonal issues basically since I got my first period at 13. And really never had regular periods. I would get like 2 or 3 a year, cystic acne, all the symptoms of PCOS. Like right these days, we would be like, she has PCOS. It would be very obvious. But back in those days, that wasn't, it really wasn't known as much. And so I was sent to dermatologists, family doctors. I was given antibiotics, birth control, all kinds of things
Oh,
for years, and finally, I finished my own training and through that realized that a lot of these things that I was experiencing actually were a problem. Even the irregular cycles, I had been taught in school that was normal. So it took me
mhm,
quite a while
mhm,
to
mhm,
realize that
mhm.
it wasn't actually normal until I actually
Yes.
did medical training myself. And then I had all of the testing done, and it was obviously PCOS. So yeah, finally got a diagnosis after a long time. And I also have had gestational diabetes um, in my pregnancies. So 2 of them out of the 3. So I have
Mm.
quite a bit of, unfortunately, a bit of knowledge about that area too. And that was what really got me interested in understanding insulin resistance on a deeper level, metabolism. So I really find all of that fascinating and how to work with people's metabolism because I find with PCOS it's different. Um,
Right.
yeah, than other metabolic kinds of issues.
Wow. Makes sense. So like you were saying, there's, a lot of misinformation or just not enough research about understanding gestational diabetes and PCOS. So what are the signs and symptoms of gestational diabetes? Like if someone is pregnant for the first time, there's so many changes they're already going through, and then they have to think about the like gestational diabetes aspect of it too. So what can they look for? What are some questions they can ask their providers?
So yeah, they do the testing around 24 to 28 weeks, and it's sort of a screening that they'll do there. But many people actually don't have symptoms unless it's really bad. But the symptoms that you might notice, and a lot of people notice these later than that time, but so keep an eye out for a bit later. But it's thirst. And in pregnancy, thirst is kind of a normal thing, but this is another level of
Oh,
thirst.
wow.
Like this
Okay.
is like cannot drink enough, always thirsty, always urinating. Now that's also common in pregnancy, but like this is another level too. Yeah.
Okay.
And then
Okay.
feeling weird or tired after eating. That's another common symptom.
But that
And
can also
feeling
happen in
hungry.
pregnancy.
Yes, all of these
Oh
can, right?
gosh.
So it's very hard to tell, especially if it's your first time being pregnant, because
Right, right.
these can feel like, oh, it's pregnancy symptoms. But yeah, so that's why I often, if you feel like those types of symptoms are worsening, then the testing is really important.
Okay, so what is the test then? If you could share that.
So, yeah, so the regular testing is 24 to 28 weeks, and a lot of patients don't develop much insulin resistance until they get a bit later in pregnancy. So, if you go at 24 weeks, sometimes you might see it there, but sometimes you might not, right? So it is always important to keep an eye out a little later too. But that test is a glucose tolerance test, and it's
Mhm.
in Canada. There's a 1 hour one that's done at that time, which means they give you the glucose drink, and they measure your glucose after 1 hour. And if that's over the limit, and they send you for a second one. And that one is a 2 hour glucose tolerance test. And if you fail that one, then you're diagnosed with gestational diabetes. So that's the standard treatment testing that they use at the OBGYN.
Okay, and then you said, so what is going off of that? What is late onset gestational diabetes? Because I know you mentioned that most people may pass the test initially.
Yeah, so for myself, I had late onset the first time. And then I delayed my test a little bit the second time to go towards the end of that window. And I failed that test, the second diabetic pregnancy I had. So the first one, like the late onset is after 28 weeks. Like that's actually just the definition. It's not really different. It just means that it's past the time they do the test, really. And the reason you can develop that is that some people, their insulin resistance isn't that bad yet until they like gain more weight towards the end of the pregnancy. And then it turns on all the genes and then you see it. So I always ask my leaner patients to keep an eye out because sometimes they gain more at the end, like 30 weeks, and then all of a sudden they're going over and all their blood sugar. So that, what I usually do there is I'll do fasting glucose in the morning, especially if they're having symptoms. But I usually have people just spot check if they have any genes for like people in their family have diabetes, for example, like mom, grandma, brothers and sisters. Then I'm like 100% check
Yeah.
because those first degree relatives are really strong genetics. So I'll do a fasting, and then you can do for Canadian guidelines, it's under 5.2, which is 95, under 95 in the US glucose units.
Thank you.
Yeah.
Thank you.
Yes. And 2 hours after a meal, I do this as well. I'll have people check just with a finger prick. It's under 6.7, which is 120. And you can also run an HbA1c, which is a glucose average over 3 months. And if that's above, 5.6, that's looking like, it's going into that area, pre-diabetic area. You can sometimes see it in the urine, glucose in the urine as well, but that's usually more severe. But yeah, those are what I do. I just do some home monitoring. And if something's looking like it's coming up, we can run the glucose tolerance test at that point again. Just get the confirmation.
So I feel like maybe it just sometimes, do patients sometimes feel like, okay, if they pass like that first test in the first trimester, then they're like, oh, like, I'm out of the like concern of it, and then maybe they like start eating, like maybe they're more
All the
cautious.
time.
Oh, okay.
Yeah, it happens all the time. Like, and people think like they can't get it, right? Because they
Yeah.
don't tell you about like that. And I see it all the time in PCOS patients. Like, they have to hit a certain point and then they'll get it. And like, maybe they haven't hit it there. So it's
Okay.
like, I find it a little like the knowledge should be kind of out there
Mm-hmm.
for the providers. This person has PCOS just because they failed this. If all of a sudden the other thing is the
Right.
baby's getting big,
Right.
the baby's growing really rapidly, then that should be checked later. Yeah.
Okay. So basically, you're not really in the clear just because you passed it the first time. So everyone, just stating that for everyone. And like you said, sometimes patients aren't always told that. So I'm glad that we're having this discussion right now.
Because it's 25% of patients with PCOS get gestational diabetes.
Wow.
And I'm going to say not that many fail that first test, but I see lots of them getting it after. So it's, it's just super common.
Yeah. And I think the other stat is like, well, so with gestational diabetes, is there an increased chance of developing diabetes after that? And then, like, I know that with PCOS, like about 50% of women develop diabetes before the age of 40, which is like crazy as well.
It's so crazy. Yeah, it totally does. And the way I sort of think of it is that pregnancy challenges those genes like really intensely. Like it really challenges like your insulin sensitivity in a way that not much other things can do. Getting older does that too. So you're kind of getting a preview into what your cards might be like later on. So yeah, take it seriously if you have it. And it means that you're very high risk if you get that.
Okay. So what are some questions that an individual can ask and like advocate for herself in the healthcare system? Like you said, sometimes providers don't share all this information with the patients at a time where they may need to know it, and it might be like quote unquote too late. So what are like questions they can ask?
Yeah, I mean, I would always like bring it, like if you feel like something is wrong, like just your intuition when you're pregnant is powerful. So always listen to it. Don't ignore it. You're usually onto something if something is coming to you. So then if you need to advocate, it's always really helpful to kind of use the language of like doctors, so that they understand why you're asking. Unfortunately, sometimes when women bring things up, they're thought of as anxious and that sort of thing. So sometimes what you could say is, my relatives have diabetes, my mother, aunt, sister, whatever, and I am feeling really weird after I eat. I'm feeling very thirsty. Like mention the exact symptoms, like in a kind of objective way. Would you mind looking at this again for me? Because I feel like something's off and I want to just be sure, and that they'll usually check it, if you ask that sort of way. So I think, just being really, confident that you can ask for what you need, and, you don't have to ignore it just because, you can go see somebody else, get a second opinion, because if you feel like something's up, it probably is, or at least you want to check it to ease your mind.
Yeah. And also, like you mentioned, you said if the baby is growing rapidly, right? So like if you as the woman notice that, hey, like I just got bigger really quickly, I guess. I guess that would be a sign as well, correct?
Yeah, like if your baby is like, these measurements they do are not accurate to any great degree, but say your baby's 20th percentile, now it's like 90th, then bring that up, because they know that, and they, this is something that is, obstetricians are always on that if they see the baby's getting big. So they will usually check again if you mention that.
Yeah, and I love that you mentioned like get a second opinion if you want to do that. I think, like I've mentioned this before on some of my other episodes, but we know our bodies better than anyone. And if you feel like someone is questioning how well you know your body, then it's okay for you to go ask somebody else for help. You're not obligated to just stick with that provider.
Yep, you're not. And it's very important, right? It's like the rest of your baby's life ahead. So if you feel like something should be checked, check it, get it checked, go somewhere else. It's not every doctor understands PCOS that well, but if you keep mentioning those types of symptoms, a provider will usually recognize that as signs of diabetes. So.
And then once if they do receive the gestational diabetes diagnosis, how can it be managed? What are different ways?
So there's so many different things you can do. So I find with this, it's very individual. So my goal is always to find the ways that the person can do that will manage their blood sugar. That is, something that works with their lifestyle that's not too extreme, but is going to be actually effective in their body. And so what I often recommend is balanced meals with protein, fiber, healthy fats, and a moderated amount of carbohydrate, and then measuring the glucose 2 hours after the meal, and then tweaking that meal until it becomes good. And that's how I do it, because everyone's different. You could give the same meal to two different people, they're going to have a different result. And so I always, use that starting point and then actually see the result is working. That's very effective, because most people really just, they're used to eating certain things. And if you can just kind of adjust what they're currently eating, like macronutrient wise a little bit, it's very doable for most people. Walking after eating is very helpful. Eating a big salad before your meals can be extremely helpful as well. So, those kinds of things make definitely the biggest difference. Unfortunately, sometimes if you go to the hospital, I went there when I had it just because I wanted to see what they would say, the nutrition class that they teach. And if that's what you're following, I would definitely suggest also to try, if it's not working for you, to try other methods too, because sometimes that method, I can see why it wouldn't work for a lot of people.
Yeah, I think the key thing to remember is with PCOS, there's a few other things to keep in mind, and everything that works for people without PCOS may not work for people with PCOS. And I actually had a dietitian that specifically works with people with PCOS. So I'll share that link in the notes below. And she specifically talks about she elaborates more on how to create those balanced meals for insulin resistance. So that will be a great resource that I'll share.
Yeah, that kind of thing makes the biggest difference, especially if you can start early. As soon as you notice, just really start tracking and checking, and huge difference with the results. Yeah,
definitely. And I think the key is also trying to kind of develop that lifestyle before you even get pregnant, right? And just having trying that lifestyle out to manage your own PCOS symptoms, regardless of wanting to get pregnant or not.
I agree 100%. It's so much easier to keep going once you've got the patterns. Yeah. So it really, it's just about continuing that, and then tweaking little lifestyle things that might be individual, things like walking, all those things. Certain people just respond really intensely to certain types of things, and you can only tell them once you try it. So
yeah, I really like that. And I tell my clients as well, keeping a journal can help. And so I think that could be important in this situation if you are going through so many changes and you want to know okay, this meal did this for me, or when I walked, this is how I felt, or stress management, all of those things. And you said every pregnancy is different, every person with PCOS is different, so that's always a good thing to connect with your own body.
It's very true. Yeah, stress really can influence it. It's interesting.
Is there any supplements or medications that you prescribe if those things are optimized and still not helping?
Yeah. So there's, with pregnancy, there's always, if you look up supplements and things like that, they're all not safe in pregnancy, right? Because in order to be considered safe in pregnancy, you usually have to be subjected to the same level of evidence that a drug has to be. And in order to do that in pregnancy, there's a lot of ethics involved. Like you have to run trials on pregnant women, which is risky. But there is some research on myo-inositol in pregnancy to prevent gestational diabetes. And this is something I recommend a lot, and I find it does really help. It's it's in food, it's in breast milk, for example, inositol. So it's it actually has been researched. So that I do feel quite comfortable with recommending in pregnancy. And then I recommend a lot of fiber, glucomannan fiber, which is basically not even absorbed into the body. It's just a fiber, so that's very safe. And that can form a gel around the food and basically slow the glucose spike after the meal. So that's another very safe supplement because it's really just fiber. So those are used. They do also use metformin and insulin. Yeah.
That's what I was going to ask you about. That's really, I don't know in Canada, but in America, that's like the first go-to, I feel like.
It is, yeah. So it doesn't work. Like I find it's like around the same as inositol, the effect of it. So yeah, and then some people need insulin. So, so that's really the main treatments that are offered.
Okay, great. And I think, the best way is like, now you're aware that these are the treatment options, but of course, ask your doctor what's best for you with the results that you have.
Exactly, because not everybody, there's pros and cons and there's risks and benefits. And metformin, just like everything else, we don't really know about its safety yet. Like there's some evidence about this, but really it's not been used enough to really fully understand that yet.
Yeah, and like metformin itself is still used off-label for PCOS. It's not really even indicated. So, but that's a different conversation, probably. So before I take questions from the audience, I wanted to ask some general questions. Like, what was your inspiration for writing your book, The 8 Steps to Reverse Your PCOS?
Well, I would say I get obsessive about things. And I sort of learned a bit about myself recently, and that I actually have ADHD, which I did not know. And so I tend to go down rabbit holes, and I decided PCOS was what I was going to do because I have it, and it's just so interesting to me. So I decided I was going to write a book on that. And so I made, I spent quite a bit of time writing that. And also just having it and seeing, just so many people struggling. I just wanted to be able to share what I could that I had learned. So that was the main reason, really.
Yeah, it's an amazing book. It definitely talks about a lot of different ways or things to keep in mind to address PCOS. As a PCOS holistic coach myself, these are the things that I talk about too. Looking at your environment that we mentioned earlier, balancing your other hormones, thyroid, and then more unbalanced meals and also inflammation. So there's so many aspects to it. It's not just quote unquote lose weight or, just exercise harder. So it's definitely a great resource that everyone should check out.
Thanks.
And she did not tell me to promote her book. I'm promoting it because I genuinely, truly believe that it is an amazing book packed with a lot of information.
Thank you.
Yeah.
Maybe too much sometimes. But it's just such a complex condition. There's so much to know about it. So.
Yeah, I know what you mean. I get really obsessed about certain things too, and I'm like, okay, I need to stop. But this was definitely used for good because there's lots of information in the book for sure.
That's good. I'm still obsessed with it, so I'm not. It's not ending anytime soon. So
And yes, it's ever changing, which brings me to my next question. Like, you were recently a reviewer for the new international PCOS guidelines that are going to be coming out. So can you tell us a little bit about your experience with that?
yeah, that was such a great experience because um, PCOS, I find one of the biggest problems is that primary care providers don't understand it very well because this is who the patients are getting the diagnosis from. And this is like who they're getting their
Right.
first experience from. And if that goes poorly, the whole thing is just set off in the wrong foot. This is where, sometimes people end up getting an eating disorder. Like I see this all the
Yeah.
time, just the way it's delivered, and so these guidelines are so important because these are really what like primary care providers are going to read to understand PCOS. So over time, like with PCOS challenge, we've been looking
Mhm.
through and just seeing a lot of problems with these, like just, how it's diagnosed is a big issue. There's a lot of lack of information about different ethnic backgrounds, even
Mhm,
though
mhm, mhm,
clearly, like,
mhm.
PCOS goes across every ethnic background, and there's some differences to know about. There's a lot of eating disorders in PCOS, and that had not been really brought to the forefront. Like, so providers really need to be aware of that before they say to a 14-year-old, just lose the weight
Mhm,
and you'll be
mhm,
okay,
mhm, mhm,
or you're never going to have children. So
mhm.
like having those like our feedback around elements like that is really, the new guidelines are going to have more kind of information just to move things forward that way. So we made all of our suggestions. We don't know what was accepted yet, but we've heard that a lot
Mm,
was. So we'll see. So that's really the missing areas, diagnosis,
mhm,
and then all of these like, cardiovascular disease, insulin
mhm.
resistance, like past menopause is still there. So just having all of that like information for primary care providers so they can truly understand
Mhm.
it. Yeah.
Wow, amazing. You said like so many great things, a lot of myths that sounds like are going to be addressed, which is amazing. And I think that even if maybe all of them are not accepted for this guideline, I think that, leaders in the community are going to continue to say these things until the message gets out there because, that is the truth. Like, you have to be careful what you tell someone during diagnosis in a short, like 15-minute doctor's visit and how it can impact literally like the rest of her life and her mental health, eating disorders, and the myth that like you only have to worry about PCOS when you want to get pregnant, but really it's like it affects your whole life for the rest of your life, whether you want to get
Mhm.
pregnant or not. So yes, all of that, amazing. And I can't
Yes.
wait to see the positive impact this is going to have.
Yeah, the advocates have done so much from PCOS Challenge. Like, if you just look at like 15 years ago, like the difference is
Hmm,
really, it's
hmm.
just what they've done. Like, they've actually changed everything. So, I think 10 more years, it's going to keep going because there's more people involved now. That's very
Yeah.
exciting.
Yes, and I think like the power of social media is being used in a positive way to raise like awareness and bring these concerns to people's attention and providers' attentions. And yeah, so it's good. Like, it's good to have the factual information because there's a lot of misinformation on PCOS as well on social media. So having these
Yes.
guidelines, getting the knowledge out there to providers. So definitely.
Yeah.
And I know I before I open it up to questions from the audience, we did have one question that was submitted beforehand. So this person said that she was eating a keto and low carb diet, but she failed her glucose tolerance test, even though her hemoglobin A1C and fasting glucose was within normal limits. Can you elaborate a little bit on how that could have happened and the relationship between low carb diets and the test?
Yeah, this is something that's very common and also very confusing when it happens because the provider like that runs the test will not know why that happened. And so they will diagnose that person with diabetes.
Mm,
And that is usually not diabetes. But, obviously following a keto diet in pregnancy is something that we don't have evidence to say it's safe. So we don't know that that's safe. So it's in a way a bit of an experiment. But this can even happen for people on low carb diets. So what happens is when you eat low carb for a long time, your muscles actually they don't dispose glucose very well. Like they just stop doing that and they become, more fat adapted. And so when you give that glucose drink, it's like a huge amount of glucose all of a sudden into a body that has not been doing that at all. And you're going to fail the test. Like almost everybody will fail who's on keto or a very low carb diet. So in order for that test to be accurate, you have to eat 150 grams of carbohydrate, net carbohydrate, not fiber. So you subtract the fiber, 150 grams of carbohydrate for 3 days before, and 50 grams of net carbohydrate for dinner the night before. Then you'll know. Yeah. So,
wow. Okay.
Yeah.
That's really good information for anyone that may have been doing low carb and has the test coming up, because you obviously want that results to be accurate and all of that. So, okay, very good to know.
Yeah. If the A1C is low, it's probably not, but you can't really tell until you actually do the carbs. So.
And A1C, like you mentioned earlier, is just like a summary of like blood glucose levels over 3 months, but really like someone can have insulin resistance for a long time before it even shows up and like impacting the A1C, correct?
Yeah, exactly. Like, because with gestational diabetes, it gets worse the later you go. So the 3 months includes like the better times too. So yeah. So it's like sort of reflective, but like usually you will see a bit of a high fasting glucose if it's really diabetes, but also sometimes people on low carb have a high fasting glucose for another reason too, because again, they can't dispose of sugar. In the morning, our cortisol spikes, that releases some sugar, and they may not dispose of it as fast. So sometimes that's misleading for them too. So, but most people who are on low carb like that, they're, if you do this, you'll be able to tell, just having those carbs and getting their body a little bit used to it for a few days.
Good to know. Very good to know. So this was such a great conversation, and I really appreciate you breaking down everything in a way that people will understand. So I wanted to know if anyone from the audience has any questions. And Sandro is on, who has been a previous guest on my podcast and YouTube channel as well. So hey, Sandro, thanks for being here.
Hi.
Do you want me to say hi to you in
real
you can,
life?
You
can. Join us. Join
the PCOS nerdiness. I'll just pick up on those two things that Fiona said there. It's really interesting. That is really showing how the individualized care is important, because it would take someone like Fiona to sit in front of someone and actually explain in detail what you need to do to make sure you're getting a real picture. And if I take that step back, then of course, that's not realistic, and it's not really possible to have like everyone on a one-to-one all the time. And that's then the importance of the guidelines. And having been on the other side as a researcher working on the guidelines and seeing what Fiona was saying about having so much input this time from advocates and other people involved, being on the other side of the receiving end of those treatments, the guidelines are just trying to, I guess, harmonize all this information. And as Fiona was saying, providing that quick reaction to someone then behind the desk seeing a patient for the first time, and having at least some sort of a roadmap of what to say to them. Ultimately, I would still go back to what I said in the beginning, which is it's very individualized, and sometimes you need really this individual attention and care to exactly what you're doing in your own life that could be exacerbating, and on the other hand, that could actually make a big difference to get things back on track.
Definitely. Thank you for sharing your perspective on that. Yeah. Go ahead, Fiona.
Yeah, no, I totally agree. And Sandro's in the research world, so it's really interesting, just to hear that perspective of like, because it's so much work, these guidelines, and I can imagine like researchers, it's so different, right, than people sitting in front of patients. So I love it that it's just become more collaborative, bringing those worlds together, because the guidelines are created for practitioners. So yeah, we really need all of it, because it's a complex condition and it's really easy to send people down the wrong path, unfortunately.
Yes, definitely. I agree. And, yeah, I think, like you said, collaboration, it's a complex condition. Like it takes a whole team, and like there are becoming more resources out there, right? Like if you need a dietitian, it's hard to find one that may understand PCOS, but there actually are some that do. It's getting out there, right? There are like personal trainers that understand how to work with people that have PCOS. There are some providers that do those things if you need like specific help in those things. But yeah, I think that I'm really excited to see how these guidelines are gonna provide more like evidence-based research and knowledge to healthcare providers so that more individuals can get the help they need.
Love it. Yes.
Yes. Yeah, so if there are no other questions from the audience or any other comments, I wanted to ask you, how can listeners and viewers find more information about you and your resources? Where can they connect with you?
Oh yeah, I'm on Instagram at Dr. Fiona ND, and I have a clinic in Toronto. It's called White Lotus Clinic. We can only work with people in the province of Ontario, unfortunately. But if you're outside of that area, there's the Endocrinology Association of Naturopathic Doctors, and they are naturopathic doctors all across North America who do extra training in endocrinology. And they're a great resource because they, definitely have more time to spend with patients and background in that area. So check out their directory too. And then my book is on Amazon as well.
Yes, amazing. And I'll share those resources in the notes, and I'll also share the episode that I did with Sandro. We talked about acupuncture for PCOS, for like stress relief, as well as helping with fertility. So that was like a really great episode as well. But yeah, this was like such a great conversation. I'm just like so excited, and I learned a lot, and I think it's going to be really valuable to everyone. And Sandro, thanks for joining us and giving us your input as well. Definitely appreciate that as always. Was there anything else, Fiona, that you wanted to mention before I sign us off?
No, outside of just always listen to what you feel is happening in your body, because like PCOS, it can change at different times, and sometimes stuff you might read might not apply to you. And so, like there's a lot of just misunderstanding out there. So, listen to your gut. If something's not working for you, try to, look for somebody who can look into your individual situation a little more deeply and see if you can get help that way as well.
Yes. And actually, I thought of one more question. So can PCOS change? Like if you have PCOS, you get pregnant, and after pregnancy, like have you seen with your patients how PCOS changes? If you just mentioned that.
Yeah, I find it changes for most people, like all in many ways. Like firstly, the older you get, the lower the androgens get, the less eggs are in the ovary. So the AMH goes down. That can alleviate a lot of things like ovulation problems. Some patients, when they are pregnant, that so much exposure to progesterone kind of corrects some things for them, and they can start ovulating after that. But some patients, they become very insulin resistant in pregnancy. That activates all of their insulin resistance genes, and they have problems with that after, or they might develop a thyroid problem after, because we see a lot of that, autoimmune. So yeah, like it can change, and that's why something's up, just be reassessed, because it's an endocrine condition that affects many hormones. So having everything checked, because things definitely change.
Yeah. Definitely. And it's so complex. Like I really want people to know that don't feel like you have to do this by yourself, and that, if you really are struggling, get the help you need. reach out to people that can provide you the help. Like I provide one-to-one coaching because it is so complex and individualized, like we discussed. But yeah, like we're still learning more about it as these guidelines are getting updated, right? So don't feel that it's all on you and you have to figure it out, and that like you feel negatively towards yourself because of the symptoms you have.
Yeah, a lot of the time it's like, oh, you just need to eat more perfectly and you'll be better. And that's not, like, for many people, that's not the answer. Like I've seen that so many times, people blaming themselves, and their problem is actually, oh, they're hypothyroid, so like there's limitations. There's some good basics to follow, but if you hit that wall, like always get yourself looked at, because there's a lot of things that could be going on.
Yeah, and like my clients, when they start with me, like most of them are not eating enough food. That's like the most common pattern I've noticed, and they have such a negative mindset about themselves and PCOS and their future. So, yeah.
Yes, I know. And yeah, it's like it all starts at the diagnosis. Like there's that negative kind of the way it's delivered, and like that can change a lot. So yeah, there's a lot of hope because you can do so much if you can figure out what's going on.
Exactly. Well, thank you, Dr. McCulloch, and thank you, Sandro, for everything you guys do for the PCOS community and for being amazing people and for being here today. And I'm sure like we could all just continue talking for hours and hours, but I guess we should put a stop to this for now.
Thanks, Dr. Patel. So nice to be here and chat with you, and just getting to know you online has been awesome as well, and seeing everything you're doing. So thanks for everything you do. And Sandro as well. You've been at it for a long time and doing so much. So thanks for that.
Thank you. With that being said, I just want to say to everyone, as always, be kind to yourself, be patient, and focus on progress, not perfection. And I'll see you guys in the next episode.
If you enjoyed this episode, please leave a review on the podcast so it can reach other listeners that need support with their PCOS. If you're watching on YouTube, please like, comment, and subscribe. I would love to connect with you. Send me a DM on Instagram or TikTok at pcos.holistic.coach. Until next time, thank you so much for tuning in.